Yes, screen could be seen. I have a view here.
So this is just a very brief presentation of our clinical cardiovascular research center, because the international and the Rochester ATTF registry is being coordinated from here. So I'd like you to get a better understanding of how we work, what our scope of work, and what we have been doing for almost more than 40 years. And I don't know if you all know, but our heart research follow-up program, or what we call now the Clinical Cardiovascular Research Center, was established by Arthur Moss almost 40 years ago. Then Dr. Wojciech Zariba took over and was the head of this organization, big department, for many years, and has continued to promote this department. And what our main aims have been is maybe other people should mute while we're talking, only if they have any question. We want to make this interactive, but there's some background noise.
I sent Chap's message already.
Okay. So our main aims initially, and even we are continuing to want to advance arrhythmia and sudden cardiac death research by improved risk stratification to identify high-risk individuals, to identify prevention modalities, to treat better patients who are at high risk of sudden cardiac death, including inherited arrhythmia, but not only that, patients who have acquired arrhythmic syndrome. And this has been our focus for many years. And in each of those areas, we have been leading research in device therapy for sudden cardiac death, drug therapy, pharmacological therapy for sudden cardiac death prevention, and also, as you all know, inherited arrhythmias that predispose to sudden cardiac death in children and young adults. And those studies have made significant impact on guideline recommendation for sudden cardiac death prevention. And this is our general structure. We have, in our department, we have between 40 and 50 people, including research coordinators, IT, administrators, statisticians, analytics, programmers, and we have been focusing in multi-center clinical trials, international studies, registry, in which people like you are participating. We have been focusing also in pilot studies. We have an infrastructure, like I mentioned, of programmers, statisticians, databases, and advanced technology. And we also want to use some big data and use large databases to better inform how to treat patients. And as you see, we had a lot of research grants funded both by the NIH and also the industry and the American Heart Association, designed to improve outcomes in arrhythmia and sudden cardiac death research. And this is the number of publications that has been advancing over the years. It's continuing to grow, more than 100 publications per year based on our databases. And also based, of course, on what we get from you, our participants and collaborators. This information is translated to clinical implications and clinical research. And based on this, as I mentioned, we have managed to change guidelines for device therapy for the prevention of sudden cardiac death. As you see, we initiated studies on defibrillator research. This is the battery of the ICD, the defibrillator that comes into the heart. Today, there are more advanced devices that can implant it only under the skin. But in any case, those studies that we began more than 20 years ago have made an impact and changed guidelines to who we should implant an ICD to prevent the risk of sudden cardiac death. And the same thing we have done for cardiac resynchronization therapy. In addition to an ICD, we can now resynchronize the heart to improve its function. And this has also made an impact on guidelines. And Sam and our team have also worked on something that can be also applicable to young individuals at risk of sudden cardiac death, which is the wearable defibrillator. This does not require implantation inside the body, but also can be implanted. It can be just placed around the body, around the chest, and prevent the risk of sudden cardiac death for a long time. And as you see here, we are focusing also on innovation in digital health, monitoring devices, remote devices that can also be used in patients with inherited arrhythmia to identify functional capacity, transmit information about EKGs. So all those components have also been integrated into our research. This is the study that Wojciech Zaryba is leading about remote monitoring of heart failure and arrhythmia in patients at high risk. And again, this is our studies on the LPTS registry, and we're going to expand on this today. And based on this data, we have managed to advance beyond understanding of LPTS, long QT syndrome, just as the disease of risking the patients of sudden cardiac death by looking at the QTC interval, but we can also now look at the genotype. We can look at also things we're going to discuss today about age and sex interaction and the risk of arrhythmic events. We can look at the effect of sex hormones during the menstrual cycle that we're going to be expanding today. So all those components and the risk of oral contraceptives in patients with long QT syndrome. So all those components have been addressed by our clinical research in our department. And these are some of our future directions in which we want to incorporate not only clinical data on the risk of the patients, but also on genetic markers, imaging data, ECG data, and biomarkers. And based on this, we can incorporate the risk of sudden cardiac death in our patients to improve outcomes and management in patients at a high risk of sudden cardiac death. Thank you.